session for today is to be taken by me. So is my slide visible and am I audible?
Yes.
Thank you.
Yes.
So after talking about infection control procedures in our ICU, a very pertinent topic and a very important topic to be discussed after that is antibiotic resistance. And I believe it is a very critical area of antibiotics these days. Just as MDR, multi-drug resistant organisms, are becoming so common in the community, likewise, the same multi-drug resistant organisms we are coming across so many pan-resistant organisms which are so difficult to treat, and it's really a priority these days that an appropriate policies should be in place, and a very judicious use of antibiotics should be somebody's mic is on. I would request everybody to.
Slides are not moving.
Okay, I have not started
Okay.
Okay. So after all the reading and after all the research, I would really say that antibiotic usage is an art, and it takes a lot of time and experience to know about the proper usage and of antibiotics. And we should be very cautious while prescribing them, and it should be a team effort, and we should bring on board the microbiologists, infectious disease personnel, and pharmacists while deciding any antibiotic which we use in our ICUs. Okay. So it's moving now? The slides are moving?
Yes, ma'am.
Okay. Yes. So I would like to take you down the memory lane with the discovery of penicillin, which was discovered by Sir Alexander Fleming in 1920s. He got the Nobel Prize for the same. This is the original penicillin mold, which was discovered by him. He made a speech at the Nobel Prize ceremony that year in 1945, and I would like to quote him. He said that it is not difficult to make microbes resistant to penicillin in the laboratory by exposing them to concentrations not sufficient to kill them, and the same thing has occasionally happened in the body. There is the danger that the ignorant man may easily underdose himself, and by exposing his microbes to non-lethal quantities of the drugs, make them resistant. So way back in 1945, Alexander Fleming was so foresighted to predict that the problem and the menace of antimicrobial resistance which we are facing these days. I mean, how many of us are aware, or in the peripheries, the clinicians who are practicing, that the dose of amoxicillin has been increased to 100 milligram per kg per day for community-acquired pneumonia. Some physicians must be still using the dose of 30 to 50 milligram per kg per day, and thus underdosing and creating antimicrobial resistant organism in the community. So I would just like you to come with me to 1940s. In the during the World War II, if a child, 2-year-old, presented with fever of 5 days along with cough and cold, developed respiratory and feeding difficulty since 1 day. So physicians seeing that child in that era must be thinking about pneumonia in this child because he presented with typical symptoms. So what antibiotic he had in hand? So it was just penicillin with him. Let's now see. We'll come to that case later again. So now let's see the timeline of antibiotics. So the history of antibiotics started somewhere around 1910 with the antibiotic Selvarsen, which was the first antibiotic to be discovered. And then the discovery of penicillin, which was made in 1929. Then subsequently further antibiotics like aminoglycoside, tetracycline, polypeptides were discovered subsequently in 1940. The period between 1950 and 1960 was really the golden age as far as the antibiotics were concerned, and we had so many antibiotics like macrolides, polymyxin, nitrofurantoins, quinolones were detected during that period. After that, like from 1970s to 1990, we really didn't have so many antibiotics which were really discovered, apart from the carbapenems. And in late 1990s and 2000s, vancomycin and daptomycin came forward. After that, we really do not have a new molecule as such. We are really just juggling between the old molecules and creating combinations just to have a combination in hand and treating the organisms which are becoming multi-drug resistant. As you see here, in 1929, the penicillin was discovered. In 1940, the penicillin resistance was found. In 1960, MRSA was detected. In 1980s, vancomycin resistant enterococcus was found, and in then 2000s, VRSA was detected, and it spilled over the community, and the multi-drug resistant organisms were a common thing in the community. This is the same representation that this is the antibiotics, and this is the number of years on the y-axis. So as you can see, from the time of introduction of the antibiotics, most of the antibiotics, they became resistant from the time of introduction to about 4 to 5 years. They were all resistant, except for the vancomycin, in which a very delayed resistance was seen of like 25 to 30 years later. We saw vancomycin resistance. Apart from that, all the antibiotics, we have the 7 groups of antibiotics. They developed resistance from the time of introduction to about 4 to 5 years. So what is the antimicrobial resistance pattern if we see it globally? How common is that? It can be seen in this map. In the purple, this is the African area, which reports about 41,50,000 deaths due to antimicrobial resistance, and not far behind the Southeast Asia region, we are reporting the next high number of deaths due to antimicrobial resistance, and India contributing in majority of these cases. So coming back to the case, fast forward, if we go into 2050, if the same child presents with similar complaints of cough and cold, fever, we have so many antibiotics now. We have amoxicillin, we have macrolides, cephalosporin, and other high-end antibiotics. But the situation is that the organism, the streptococcus and the staphylococcus, is not sensitive to either. So it was published in the review article published in AMR 2014. It was predicted that in 2050, if we do not mend our steps and if we continue the irrational use of antibiotics, antimicrobial resistance will be the #1 cause of death, and will lead to a high healthcare cost also. So coming back to the burden of the disease, WHO has predicted that, published that infections caused by multi-drug resistant bacteria amount to about 7 lakh deaths across all ages, of which around 20,000 are in newborns. In Europe also this entity exists, and multi-drug resistant infections are reported in about 30% of total cases. Southeast Asia is the really problematic zone, which reports 83% of children with E. coli resistant to first-line antibiotics. Recently, the USA study also published 20% of pediatric patients receiving colistin to treat the already multi-drug resistant gram-negative bacteria developed resistance. So this is the WHO came into action, and they proposed a priority pathogen list, which was discussed by the earlier speaker. So they defined the critical priority organisms such as Acinetobacter, Pseudomonas, Enterobacteriaceae. They should not get resistant to the antibiotics. They are sensitive, that is Carbapenam and the third generation Cephalosporin. The high priority organisms are Enterococcus, Staphylococcus aureus, Salmonella species, and they should remain sensitive to vancomycin and fluoroquinolone. The medium priority organisms are Streptococcus pneumoniae and Shigella species. Now coming to the definitions which were proposed by WHO, similar to the multi-drug resistant and XDR and PDR definitions we have in TB. Multi-drug resistant organisms are the ones which are not susceptible to at least one agent in the 3 antimicrobial categories. Similarly, in XDR, organisms are those which are not susceptible to at least one agent in all, but 2 or fewer antimicrobial categories. Coming to the pan-drug resistant, as the name suggests, these organisms are not susceptible to any of the agents across any of the antimicrobial categories we have. This was the Indian data published recently in 2021, and it was also shown by Singh sir. So this was a study done for 5 years. It was done in southern India, in Mangalore, to see the WHO priority organisms in their own, the incidence of the WHO priority organism in their own setup. They saw that the E. coli was the main organism which they found to be positive, followed by Staph aureus in 252 cases. These E. coli organism was resistant to the third generation cephalosporin in 72% cases, which was very high. And similarly, MRSA was found in 52.66% cases. So after reading this, I was very curious, and I went and took out my PICU data of 2020. The number of samples which were sent in the blood cultures were 402, and out of which 7.4% was our positivity rate. Respiratory samples which were sent in the form of tracheal aspirates, the positivity rate was quite high in 45.7. Now, looking at the breakup of the organisms which were isolated in our last year data, Candida was the most common organism which was isolated, followed by Enterococcus, E. coli, and Acinetobacter and Pseudomonas species. This was the antimicrobial resistant pattern which was seen when Acinetobacter was evaluated. So we saw the resistance again, imipenem, meropenem, peptase in number of cases. When we saw the antimicrobial resistant pattern of Pseudomonas, we saw the same type of resistance pattern across the antibiotics. So where are we? The problem is huge, and the situation is very gloomy, with the emergence of these multi-drug resistant pathogens becoming so common everywhere in the community, in our ICUs, everywhere. We are using the antibiotics left, right, and center. Whenever a patient comes to our ICU, we just give oxygen antibiotics without knowing which infection we are treating. So we have to really think hard before starting any antibiotic, and we should start with the narrowest possible antibiotic, and really it should be a team effort. because new antibiotics, as we know, have not really been produced in the last decade, and the rational use of antibiotics is what is required these days. So, as discussed earlier, so we have to have our infection control policies in place. We have to have our aseptic protocols in place before upgrading antibiotics or before asking for more antibiotics. And with this comes the Antibiotic Stewardship Program. So I would just like to briefly tell you about the history of Antibiotic Stewardship Program, which was originated in the USA. So in July 2004, the Infectious Disease Society in America sent a white paper to their parliament stressing the rapidly growing public health crisis in the emergence of bacteria that were resistant to many. So it was conceived way back in 2004 when we had not heard about the Antibiotic Stewardship Program at all. And acting on this, the Senate, the Parliament passed the Senate Bill 739, which the countries all over the world are trying to follow, which states that all the hospitals should evaluate their antibiotic use and to create an oversight committee to monitor the responsibilities for irrational antibiotic use and proper usage of antibiotics. So this was the genesis of Antibiotic Stewardship Program. So what is Antibiotic Stewardship Program? It is a very complex thing. I have just tried to simplify it. It is a program to monitor the use of antibiotics. It should be a coordinated effort by a team of pharmacists, microbiologists, infectious disease specialists, and a medical team. In countries like European and America, a clinician cannot prescribe antibiotic on his own. It has to be validated by a pharmacist and a microbiologist, which is very different from our country, where even a quack can give antibiotic and prescribe it. So there should be a law, and there should be a government control over this problem we are facing in this part of the world. What it will lead to? It will lead to less of toxicity of the antibiotics, selection of resistance, and selection of virulent organism. And with prolonged use of antibiotics, there is a menace of Clostridium difficile. It will also reduce this occurrence. So it should be combined with comprehensive infection control policy to limit the emergence and transmission of resistance in the community. It will also subsequently reduce the healthcare cost without adversely impacting care. So the policy which should be followed is preventive. We should not be upgrading antibiotics and changing antibiotics. We should be treating the cause. We have to go back to the basics, and the infection control and the Antibiotic Stewardship Program should really be at the center. So I'll be just briefing you about the guidelines for Antibiotic Stewardship Program. There should be Antibiotic Stewardship Committee, and it should be routinely be audited in computerized surveillance, and there are separate software to monitor and audit them. It should be taken up by all the institutes. There should be a very proactive role of microbiology lab, and they should work in close coordination with the clinicians. And we have to regularly monitor this process and also monitor what impact this Antibiotic Stewardship Program is having on our outcome. The outcome, that is antimicrobial resistant organisms which we are having in our isolates. So how to go about this antibiotic stewardship? We have to identify what antibiotics we have to give depending on the patient's condition. Like, what is the patient's age? Is he a neonate, or is he a immunocompromised patient on immunosuppressive therapy, or is he Does he have a history of previous antibiotic exposure? Which area does he live? Any comorbid conditions like renal failure or things like that? And we have to also know about our own ICU antibiogram, which is our bug, which is a common resident in our ICU. We have to cover antibiotic according to our own hospital antibiogram. We also have to keep in mind and review the previous lab reports and susceptibilities if this patient is having, and our own hospital records. We have to be in constant consultation with our own pharmacist and monitor drug levels wherever appropriate, wherever we do not have any sensitivity to any drug, we have to monitor the drug levels. And it should be collaborated with an infectious disease specialist or a microbiologist. So, the antibiotic usage should be timely, but it should not be too late also. It should be very apt, or it should be very timely. It's not that if a patient of bronchial asthma is admitted in our ICU and is on ventilator, he needs to be on an antibiotic. We have to be very judicious, or for that matter, any poisoning case or hanging case, just because he's in our ICU, he does not need to be on antibiotics. It needs to be very appropriate. So we need to know what infection we are suspecting. Are we suspecting any bloodstream infection or meningitis or pneumonia? Because our choice of antibiotic will depend on that. We should also be familiar with our PK/PD data, that is the pharmacokinetics and the pharmacodynamics parameter. I will be discussing about these in my later on slides. So suppose if we have isolated a organism, for example, Acinetobacter, it is pan-resistant. It is not sensitive to even a single antibiotic. We can ask a microbiologist to give us the MIC values, and if the MIC values of meropenem are in the intermediate zone, we can try giving meropenem in constant infusion over a prolonged period of time, so that an adequate level of that antibiotic is there to have effect. I will be discussing this in the later on slides too. We have to be very cautious if the child is deteriorating, he's having shock or developing BAC. The escalation of the antibiotic should also be prompt. Similarly, the de-escalation of the antibiotics, suppose the child was on ventilator or on non-invasive ventilation, now he's oxygen out, he's hemodynamically stable. We should be also timely de-escalating our antibiotics too, based on the microbiological data and in hand. So after this escalation and de-escalation, we have to think what infection we are dealing with. Suppose it is a pneumonia or a meningitis in a big child, the antibiotic duration of 7 to 10 days is adequate. But if we are dealing with osteoarthritis or infective endocarditis, a longer duration will be needed. So we have to have a broad aspect while deciding all these things. And we should really be thinking. So this is about the pathophysiological and treatment-induced alteration in the critically ill child. Just a second. I'm just trying to pull out my pointer. So the way the body acts, the effect the body has on the drug is called the pharmacodynamics. So in a critically ill child, there will be intestinal atrophy, there will be depressed splanchning, perfusion. There will also be increased or decreased cardiac output depending on the condition of the child, if he is in shock or is in volume overload. If there is tissue hypoperfusion, there can be decrease in the GFR and the increase in GFR, which will have implication on the pharmacodynamics of the drug. Like we know, there are lipophilic drugs and which have hepatic clearance, and hydrophilic drugs which have renal clearance. So this all conditions will impact the absorption, distribution, metabolism, and excretion of that drug. So for example, if there is oliguria or anuria in the child, there is decreased GFR in the child. So a drug which is having a renal clearance will build up and lead to further nephrotoxic effect in the child. So this all has to be kept in mind while deciding upon the dosage of the drug. Coming to this was about the pharmacodynamics aspect of the while deciding the drug dose, and this is about the pharmacokinetics. So as you can see, this is the time after administration, and on the y-axis you can see the drug concentration. So we have to know that certain drugs are time dependent and some drugs are concentration dependent. Why is it important to know about this? Because the dosing of the drugs and the time in which we give the infusion depends on that. So the drugs which are time dependent, such as beta-lactam antibiotics, you can see this MIC. MIC stands for minimum inhibitory concentration. For the beta-lactams to act, they have to have a certain drug dose at all time. So it will act more if we give more frequent dosing. That's why we give peptides and meropenem more frequent at more frequent intervals, like QID or TDS dosage, like that. Or we can give even a continuous infusion to maintain a drug at MIC level. So this was about time dependent. There are certain concentration dependent drugs such as aminoglycoside, which has an effect during its peak. So a loading dose of this antibiotic will create a maximum concentration of the drug at that particular time, and then the post antibiotic effect will last, and you will require to give less frequent dosage of that antibiotic. You need not give more frequent. They can be safely be given in OD or a BD dose. Then there is something called this is AUC's area under the curve by MIC. So the drugs which have both these mechanisms as their pharmacokinetics, that is, they are both concentration dependent as well as time dependent, they act by this mechanism, such as fluoroquinolone and vancomycin. So these drugs need to be given more frequently, and they need to be given in infusion for their maximum effect. So the area under curve is called therapeutic index. So I hope I was clear, and the concept of the concentration and time dependent is clear now. To make it more interesting, I have a case scenario with me. So a 1-year-old boy with uncomplicated UTI was admitted with us and was on injection amikacin 12-hourly. However, due to some problems, the attendants are requesting for discharge, and they assure you that they will be visiting you once a day in your clinic to get the injection. So I would request the audience to really be interactive and tell me, would you allow this? The residents can answer. Okay, sir has answered. So we will allow this, and I would like to go back to the previous slide. So we see aminoglycoside is a concentration dependent drug. So it has to be at a peak at one moment of time, and then the post antibiotic effect takes care of the rest. So even if you repeat aminoglycoside after 24 hours, the post antibiotic effect will take care. So this is the most important slide of my presentation. Before starting any antibiotic, we need to know the mechanism of action of that particular drug. So as seen, certain antibiotics have inhibition of nucleic acid synthesis, such as sulfonamides, metronidazole, quinolones, rifampicin. Some antibiotics inhibit bacterial protein synthesis, such as macrolide, aminoglycosides, chloramphenicol, clindamycin, and tetracycline. Some act on the cell membrane, such as polymyxin, and some inhibit cell wall synthesis, such as the penicillin group and cephalosporins and the vancomycin. So this needs to be known, because while deciding combinations, we have to keep this in mind. Suppose a child is having community-acquired pneumonia and somebody prescribed amoxicillin to cover for streptococcus and a combination proxycillin to take care of staph. So is this combination justifiable? Audience?
Please repeat that, Arpita.
Okay, ma'am, I was just saying that a physician in the periphery has advised a child of pneumonia with amoxicillin plus cloxacillin combination. So is it justifiable, or is it a rational use of antibiotic? So I believe it's irrational use of antibiotics. So because both the antibiotics belong to this category, they are synthetic penicillins, they will have similar mechanism of action. So it is superfluous to add another drug. One drug is sufficient enough. So this slide summarizes both my earlier mechanisms, that is of site of action and the pharmacodynamics. So as already discussed, the beta-lactams, the penicillin, the cephalosporin act on the cell wall, and they have a time-dependent pharmacodynamics. The daptomycin polymyxins act on cell membrane. They have a concentration-dependent pharmacodynamics. The macrolide, the tetracycline aminoglycosides, they act on the ribosome, and they have a combined time and concentration dependent action. So more frequent antibiotics and over longer period of time will be beneficial. And the quinolone, metronidazole act on the nucleic acid, and they are concentration dependent. So less frequent administration of this drug in OD or BD dose is sufficient to act on the bug. After discussing about the mechanism of action of the drug, I would like to discuss in brief about the antibiotic drug resistance mechanisms. So the drug resistant mechanism can be by increased efflux, like it's rapidly pushed out of the cell. So aminoglycosides, beta-lactams, macrolides have this mechanism of action. The aminoglycosides, beta-lactams also have target site alteration as their drug resistant mechanism. Sulfonamides, trimethoprim have target amplification as their mechanism of resistance. And there is a certain antibiotic inactivation in case of aminoglycosides, beta-lactams, and there is decreased influx. The drug is not able to enter only in case of aminoglycosides and beta-lactams. So this is nothing but just the summary of the earlier slide. Depending on the antibiotic, the drug resistant mechanism which they develop. So the problem is grave, and we have to really stop this antibiotic resistance, because imagine a child who's admitted with you in your ICU, and you have started with a broad spectrum antibiotic. At that moment of time, the flora of that child will be exposed to that broad spectrum antibiotic, leading to resistance developing in the organism. And when this organism spills over the community by plasmid mediated exchange, it will lead to multi-drug resistant organisms in the community, because if we are not following, if we get a multi-drug resistant organism in the ICU, we are not following the isolation practices, the bug from one patient may transfer to another patient, leading to multi-drug resistant organism in that particular patient, and by health, it can be transferred to the healthcare personnel, to the surfaces in the environment. It really will lead to development of multi-drug resistant organisms in the community. So we have to make judicious use of antibiotic and prescribe the narrowest possible antibiotic which is available. However, a caution should be exercised if the child is very sick, is having shock, or you do not know what is the site of infection or the organisms you are dealing with. You can safely go on to prescribe a broad spectrum antibiotic, but timely de-escalation is what is important. After discussing about the drug resistance mechanism, I would like to give a brief about how to interpret if there is an organism in the culture sensitivity report. So most of the labs across India, they use the disk diffusion method. This is the picture of the disk diffusion method, where you can see the zone of inhibition around the antibiotic. So this is the disk diffusion method, but what is preferred is the MIC, or the minimum inhibitory concentration, because that will help us in deciding the dosage of the drug. Then there are certain molecular tests which are very new. What it does, it is simply a PCR test which detects the resistant gene in the organism. So this can detect the resistant gene in the organism which we are testing, and the results are available in 4 to 8 hours, and then we can decide upon the antibiotics. But what is important is how we interpret the culture sensitivity report, which we seldom see in our ICU rounds, because if we are getting multiple sensitive antibiotics, we have to be very judicious which antibiotic to choose. So as the name suggests, we know that the minimum inhibitory concentration is the lowest concentration of the drug, which prevents visible growth of the bacteria. For example, we have a patient with uncomplicated UTI who shows a culture growth of Klebsiella pneumoniae to the tune of 10 to the power 5. We get the culture sensitivity report. Just a second. We get a culture sensitivity report, and the Klebsiella is sensitive to amikacin and gentamicin. And the MIC they said is MIC of 4 for amica and MIC of 2 for gentamicin. So usually a clinician will go for gentamicin because we see that the MIC value is low here. But what we are not seeing in this report, what the microbiologists are not reporting, is the MIC breakpoint. So in order to choose the antibiotic, we need to know the MIC breakpoints. What is it? MIC breakpoint, while choosing the antibiotic, the antibiotic which should be chosen is the one which is farthest from the MIC breakpoint. So we know that in this case of Klebsiella, amikacin has a breakpoint at 16 and the MIC was 4. So this drug is farthest from its MIC. Whereas if we chose gentamicin, the MIC would have been very close to the MIC breakpoint. However, both were sensitive. So while choosing, we have to take this into account, and we can simply do that by taking a ratio between MIC breakpoint and the MIC. For that, the higher the value, we should choose that particular antibiotic. So for example, in this particular scenario, amikacin should have been our preferred. And what can be suggested to the microbiologist, that while reporting the culture sensitivity report, they can just add a line that creeping MIC values were observed for gentamicin. So so it is less effective than amikacin, and amikacin in this situation should be used or preferred. I would also like to emphasize this point that the MIC breakpoints vary for each antibiotic and between organisms too. So the microbiologists are more familiar with this, and they have a complete guidelines as suggested by CLSI recommendations. So this is different for antibiotic as well as the organism. Just to make it more interactive, I have certain situations and I would request you to answer in the chat box. So we get the culture sensitivity report like this, and our organism was sensitive to Pseudomonas and levofloxacin. The Pseudomonas was the organism and it was sensitive to ciprofloxacin and levofloxacin, and these were the MIC and the MIC breakpoint. So what antibiotics will we choose? Anybody can answer in the chat box. I didn't get any answers. So like in this situation, because ciprofloxacin MIC is very close to the MIC breakpoint, we will avoid this drug and we will be choosing levofloxacin because it is farthest from the MIC breakpoint, and it should be mentioned ciprofloxacin MIC creeping to the MIC breakpoint. And similarly in this example, we got a culture sensitivity report, the organism sensitive to teicoplanin and vancomycin. In this, we'll be choosing teicoplanin because it is farthest from the MIC breakpoint. So we should be choosing teicoplanin in this situation. I would also like to emphasize here that a clinical judgment is also important here. Suppose you are treating a meningitis or certain deep-seated infections, so you can choose your antibiotics accordingly. After discussing about the antibiotic sensitivity testing, I would like to stress upon the fact that certain organisms are intrinsically resistant to certain antibiotics, and we should be familiar with that. And we cannot request our microbiologists to give the culture sensitivity report against that particular antibiotic, because that organism is itself intrinsically resistant to that particular antibiotic. So like Enterococcus faecalis and Faecium, they are intrinsically resistant to cephalosporin Clinda. Pseudomonas are intrinsically resistant to MP, augmentin second and third generation cephalosporin, cotrimoxazole, and Acinetobacter is intrinsically resistant to ampicillin, augmentin, chloramphenicol, like that. So what is the risk factor? Why this antibiotic resistance happen? So as already discussed, it is due to indiscriminate use of antibiotic, inappropriate combination of antibiotic, underdosing, overdosing, and using of the broad spectrum antibiotic. I've already discussed that we are exposing host flora to the antibiotic, the broad spectrum antibiotic, in turn leading to the MDR bacteria, and that in turn spills into the community. Apart from that, biofilm formation is really a big problem in chronically admitted ICU patients. It develops in indwelling catheters, lines, and this really should be taken care of, and regular care of these indwelling catheters should be a policy. We should also be familiar that certain bugs also change, like Staphylococcus aureus will start producing toxin. So the antibiotic which we were giving is not acting on that. In that situation, you can always make use of Clindamycin, which is known to act on this Staph aureus, producing toxins. I am just giving a brief about the antibiotics now and what is their spectrum of activity, because we need to know about this before we choose the antibiotic. So meropenem or imipenem, this is the broadest antibiotic which we can give. It acts against methicillin sensitive Staph aureus, Streptococcus, gram-negative. It has a broad spectrum gram-negative coverage. It also acts on Pseudomonas, Enterococcus faecalis, and also has anaerobic activity. So I have seen several times in the rounds that the residents have a habit of giving meropenem plus metrogyl. So there is no rationale behind giving meropenem plus metrogyl because meropenem itself has anaerobic activity. We need not give metrogyl along with that. Coming to Monobactam, the prototype being Astronam, it is effective against aerobic gram-negative bacteria. It has no gram-positive or anaerobic coverage, so the spectrum remains similar to aminoglycosides, but without the renal toxicity. Then comes the aminoglycosides. It acts against the aerobic gram-negative bacteria, including the Pseudomonas, mycobacteria, the atypical infections like Brucella, Nocardia, and it also is known to have a synergistic effect with beta-lactams when we have to have a synergistic effect while treating a case of infective endocarditis to treat enterococci and staphylococci. So usually we give a combination of aminoglycosides and beta-lactams there. Clindamycin, as already discussed, it covers the MSSA, Streptococcus and anaerobes. It also acts on toxin-producing staph, but it has no gram-negative or enterococcal coverage. The next class is the glycopeptides. We know vancomycin is a type of glycopeptide. It has activity against gram-positive, including the MRSA, cons, Streptococcus, Enterococcus. However, it will not act against the VRSA, that is the vancomycin resistant staph. It also acts on the gram-positive anaerobes, and we have to take into consideration while prescribing this, if the organism, if the staph is sensitive to beta-lactams, it should be preferred, and vancomycin should be reserved for treating MRSA only. Linezolid is, as we know, that it is a static drug and not cidal. It has an excellent oral bioavailability. So by giving oral, it has the same bioavailability as the IV. It is active against MSSA, MRSA, Enterococci, including the VRE and Streptococcus pneumoniae. However, it has no activity against the gram-negative organism. Coming to the streptogramins, so it is a bactericidal activity. It is approved for use in skin and soft tissue infections only. We seldom use it in pediatric patients, and it has activity against a wide variety of gram-positive bacteria such as MSSA, MRSA, cons, Streptococci, VRE. Coming to colistin, the colistin which we are resorting to now is not really a very new drug. It was very ancient drug, a very redundant drug, but we are resorting to it because it was not used because of its side effects, the huge side effects. But as we were not using it, it is still sensitive to many of the organisms, and we usually resort to colistin in our ICUs when we get multi-drug resistant organisms. It binds to phospholipids in the cell membrane, causing disruption. It is the most commonly used therapy in case of MDR, Pseudomonas and Acinetobacter. It has a bactericidal effect. However, we have to be cautious because it is also a nephrotoxic and a neurotoxic drug. So we have to take care that we do not combine colistin with other nephrotoxic drugs like aminoglycosides and vancomycin. We should avoid that combination. So a rational use of antibiotics is required in the PICU. What infection we are dealing with, Is there any fever, temperature instability, CRP, procalcitonin is elevated or not? Is it really a bacterial infection? Does this child need antibiotic? We have to be thinking. Also, what kind of infection we are dealing with, community or hospital acquired. The site of infection will determine our choice of antibiotic, and what are the likely pathogens. And also, we have to now take care about the antimicrobial susceptibility. We have to see the culture sensitivity report with great caution, and then decide between two sensitive drugs. So it is a common practice prior to starting antibiotics. We have to send cultures from relevant sites, and we have to avoid broad spectrum antibiotics, especially the carbapenems and the third and the fourth generation cephalosporins, as well as vancomycin, because these are the drugs which are available when we treat VRE or extended spectrum beta-lactamase infections. I think I am running short of the time, so I am skipping this common infections in the PICU. Sir has already briefed us that our asepsis protocol should be in place, and we should take care, and WAP bundle should be followed judiciously. Any lines, central lines or catheter should be cleaned. Proper care should be taken. A word about the extended spectrum beta-lactamase risk factors. So children with longer hospital stay, with indwelling catheters, abdominal surgery, gut colonization, prior use of antibiotics, mechanical ventilation are at risk of ESBL. What is that ESBL? When an organism is resistant to second and third generation cephalosporin, we label it as ESBL resistant. So to choose the antibiotic in the case of ESBL, if the child is having less serious infection, he's less suppose, for example, he is having UTI or something, less serious infection, and if his MIC is low, then the treatment can be with beta-lactams or fluoroquinolone. However, if he is
सुनो ये लिखा है ना, एक हफ्ते के अंदर अगर हम लोगों ने नहीं लिया तो कैंसर.
Okay, so if there is serious infection, we have to hit hard and hit early, and in that case we will not use beta-lactams, we have to use carbapenems. Recently an article was published in JAMA, which is by Merino trial, where they saw that ESBL producing E. coli Klebsiella, they treated them with either peptaz or meropenem. The 28 days mortality for peptaz was higher than meropenem. So whenever you see an ESBL in a serious infection, you have to hit hard and you have to hit early with a carbapenem. Merely giving beta-lactams like peptaz will not have any effect. I think this is my last case scenario. So a 4-year-old boy presented to our ER with multiple pustules, multiple abscesses in the body, community acquired, probably staphylococcal or streptococcus pyogenes, without any premorbid condition. He presented to us in shock and other organ dysfunction, oliguria, and when we did an X-ray, we found this picture on the X-ray. So I would ask the residents to tell me which antibiotics will we prefer in this. Anyone? So as rightly said, we can, so we can give beta-lactams, and if we are suspecting a toxin producing staph, we can add a clindamycin with our combination of beta-lactam. So with that, I come to my last slides. So prevention is really the goal which we should follow. Preventing of infection, a strong asepsis guidelines protocol should be followed, hand hygiene should be practiced, and standardized culture should be done, use of biomarkers very wisely such as the CRP, TLC values and the procalcitonin, and appropriate and judicious use of antibiotics. Take home messages. So we have to really think before starting of any antibiotic, and it should be a team effort, and early identification of sick patients and prompt use of antibiotics in that case, appropriate broad spectrum antibiotics in certain conditions, and we have to keep in mind the pharmacodynamic and pharmacokinetics of the drugs while deciding upon the dose and the frequency and the infusion time. And we have to really follow the clinical picture of the child while deciding the escalation and de-escalation of the antibiotics. We should be familiar with the antibiogram of our own hospital and our own ICU, and we have to de-escalate at the earliest. So thank you very much, and thank you for not using antibiotics and judiciously using antibiotics. Any questions?
I think Dr. Vimla is here. I had a direct message to her. Does she want to say something? Or if she's not here, that's okay. So very nice compilation. All three of you have done an excellent job. And Vimla is there. You want to say something, Vimla?
Ma'am, I'll just repeat what Arpita said, that we have to really work together on choosing the best antibiotics for our patients. And we must be aware that we have a lot of resistant bugs around, and the real solution is in maintaining our infection control protocols, because the better we are at maintaining infection control protocols, the less resistant infections we'll have to treat. So that is something I think that we should really keep in mind. And also, I'll say that when Arpita is saying send cultures, I want to add to it that send appropriate cultures and correctly collected specimens, because the result will just depend on what you send us. So if you send us, you contaminate the specimen while collecting it, then obviously the report we give you will be that we have not found anything for you. So if you are going to say, like when you're collecting a blood culture, if you just happen to contaminate it with skin flora, then the report will be that of the skin flora, and there's very little we can do about it in the lab. We cannot change the flora for anyone. So careful collection is a very, very important aspect of the antibiotic policy. Careful collection, timely collection. Collect before you start the antibiotic. Generally, there is always those 10 minutes available to you to do a culture collection before you start antibiotics. So if we give ourselves those 10 minutes, then we are probably going to really help our patients. I think at this moment, at the end of a very long session, very nicely taken session to Dr. Arpita, that was the only session I heard fully.
Exceeded my time.
Very nicely done session, Arpita. And I'm so glad you covered all the aspects a little bit at least. And I hope, ma'am, one of the other times you will also get people to talk about infection control practices and sample collection. I think these two things are something
that would be for our residents, Dr. Vimla. We'll do that for our residents.
Thank you, ma'am. Thank you.
Wide audience, not for them.
Thank you, ma'am. Thank you. Thank you.
Thank you all for joining us today. That was, I think we do not have any questions. So that was all for today, and we'll be joining and meeting again tomorrow for pulmonology as a subspecialty. So I hope everybody joins us again tomorrow, same time, 1 p.m. Thank you all. Thank you for your precious time.
Excellent presentation. Thank you.